So with this, we will now move on to our next session, TechMed. This session will be discussing various facets of emerging healthcare technologies that have the potential for large-scale impact on people's health as well as health systems and the consequent impact on the bioeconomy. The idea is to deliberate on the big opportunity for making a difference at scale through medical technologies, be it in healthcare access, infection prevention, or NCDs. With this, I'm pleased to invite the moderator for this session, Ms. Deepanwita Chattopadhyay, Honorable Vice President ABLE and Chairman and Managing Director of IKP Knowledge Park. Joining with her is the keynote speaker, Dr. Nachiket More, visiting scientist, Banyan Academy of Leadership in Mental Health and Commissioner, Reimagining India's Health System, a Lancet Citizens Commission. And the speakers, Mr. Suresh Subramanian, Partner and National Life Science Leader, Ernst & Young LLP, Dr. Chandrasekhar Nair, Director, Big Tech Labs and Mall Biodiagnostics, and Dr. Anirvan Chatterjee, Co-founder and CEO of Haystack Analytics. Ms. Deepanwita to kindly take over the session.
Good afternoon. We are running extremely late, and I understand that we have to make this session both engaging, interesting, and try to reduce time. So there are three boundary conditions that our president has given me. So with that, I'm not going to give any introduction. I'll request Dr. Nachiket More to make his presentation, please. While Nachiket walks in, I have to say, I know Nachiket for the last almost 30 years. He's an amazing thought leader. Nachiket, to you.
I want to thank Deepanwita, Dr. Vijay Chandru, and the ABLE team for inviting me to this wonderful discussion. I'm an economist. I'm not a technologist. And I was asked to give a somewhat broad perspective on what is happening. I work in health systems design and what is going on there. Two questions I was asked to focus on. One is, why do we need universal health coverage? And then second is, how are we going to get it? And obviously the connection back with technology, if there is any, and there isn't. If you see many of the conversations out there in the world, there is a rights-based perspective that is used often. It's justified on a welfare kind of impact, in which there is a sense that this is good for the poor, this needs to be done. Unfortunately, in many countries, including India, where growth is flagging, and there is a sense that we need the money to jumpstart growth, the welfare conversation doesn't go very far, because then people want to say, we want to reserve these resources for growth. And which is why you get very small schemes, insurance schemes, other schemes being launched, which have hardly any money associated with it, because there is a feeling that at least we have to do something. We can't really solve the universal health coverage problem, but let's actually do a little bit so that there is some sense of progress out there. And clearly their welfare impact is enormous. There is new papers by Piketty and others on India, which shows that somewhere near 90% of our population has a per capita income of only $1,200 per capita, comparable to South Sudan, one of the poorest countries in the world. And 10%, all of us in this room, we're enjoying lifestyles comparable to the Scandinavians. On a PPP basis, our per capita incomes are closer to $60,000 US, which is a stark difference in terms of, and in my role as a Gates Foundation head, I worked in Bihar and UP, Gates Foundation head in India, not in Seattle. I work quite a bit in Bihar and UP, and the reality on the ground is very consistent with Piketty's findings that there is an enormous challenge out there, and health is an important concern that we're not able to address if the government is not able to provide it or some other provider is not there on this. And there is no doubt that there is a need to accelerate growth. The question is, where is growth going to come from? There is a belief that we need these large national initiatives. And for the longest, I was a banker in a previous avatar. There was a belief, build infrastructure, build roads, build airports. This is what will jumpstart growth. As the young people say, there's been there, done that. And we haven't seen the growth. If anything, you're starting to see it gradually edge downwards. I was looking at Chinese numbers. China grew at a 9 to 10% per year since 1978, all the way until 2018. That is the span with which they have actually moved people out of poverty. We are nowhere close to those growth numbers. Because my sense is one of the reasons why you don't see that and why you see this in China, we haven't really spent time thinking about what are the barriers to local growth. Why is it that the large economy that we are cannot jumpstart the opportunity on the ground itself? And there are many barriers to that growth, which are different from the barriers that you might see from a national perspective. Clearly, access to finance is a big problem. Education is a big problem, but so is healthcare. The continuing problems of malnutrition, for example, there is a 20-point IQ drop that is associated with it. Right? Imagine entire populations that are operating at IQ levels, which are permanent changes that are lower. You can see why education outcomes, other outcomes are not at the level that they should be. We haven't dealt with the old problems. The newer problems are now starting to take over. Diabetes, hypertension, mental illness. State like Kerala, Pathanamthitta, for example, now has a diabetes rate of 25%, undiagnosed, untreated. Which means by 2030, it is possible we'll have an epidemic of amputations there. Every home an amputee. Right? Imagine that horrific reality for our most developed district in the country. In these environments, growth cannot actually prosper. Certainly local growth cannot prosper. And we're going to have to then think about what is it that we can do to eliminate these barriers. And financial instruments like insurance, which has been these days touted as a solution, they are very useful for protecting you from the financial shock of poor health. They do nothing to improve your health. And they have no connection actually on the ground with how do I get rid of diabetes, how do I get rid of hypertension, what do you do about mental health. There's no connection at all between these two. And we have to solve this issue. Of course, the question is, for the moment, let's say we agree with me that UHC is needed for growth. I certainly believe that it is. The second question that comes up, which I was asked to debate on, is how are we going to get there? It's all very well to talk about it. It's a slogan everybody loves. And I think December 12th is UHC Day. Every so often we celebrate it and we think about what is going on. It is clear, though, that if we have in mind, and many people do, this idea that an MD in general medicine, called the family practitioner, will show up in every village. The average US GP serves 1,700 individuals, which is roughly the level of what in India we would call a sub-center. Right? At a sub-center level, we will have a MD in community medicine or family medicine show up. And at the block level, about 2 lakh population, we'll have cardiologists, oncologists, psychiatrists. This is not going to happen. There is no evidence that this kind of supply is in the offing in the country. And those that are indeed graduating at these numbers, the world is aging and there is massive demand for Indian talent out there. If we are to solve it, I believe we can't focus on the weaknesses that we have, no doctors, no nurses, and to focus on what I call a strength-based perspective that we have. One of our most important strengths is that we have an enormous supply of human resources who need desperately jobs in every part of the system. And we now have good evidence that these individuals, maybe just high school graduates, of which there are many, 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 can be trained rapidly to provide comprehensive primary care with the help of good protocols and good technology. Alaska, has done this for 50 years in its icebound villages, where the nearest villages are 1,000 miles apart and completely cut off, completely isolated. Each village, 200, 300, 500 households, very comparable to ours, right? And, some progress has happened in this. IIHMR has, for example, developed now a new program, a diploma program, which is very different from the ASHA, the A&M that is trained on one thing, what is the other. In 4 months, you can't train people on 20 diseases. The approach that you have to take is fundamentally different. And it's really engaging the individual with the technology in a way that is seamless, so that the two of them together actually provide you the guidance that is needed. If I now look at the development outside the healthcare space and look at optic fiber networks, even this budget, the finance minister made an announcement, BharatNet, a project that's been, I think, ongoing for 20 years now. And they are sitting on, I think, over 1 lakh crore of cash. Every year, the amount that they collect from the mobile phone companies keeps accreting. The belief is finally it will give us, and I believe maybe it will take 5 years longer, to give us very high quality optic fiber at the remotest possible locations. What that means is I don't have to do edge computing. I can actually give a lot of the computing capability can happen on the cloud, and the front-end machines then are only required for data capture, and the pricing then collapses in the ideal state, so that then I can imagine putting in a whole lot of functionality at the primary care level to make this, the reality of this health worker plus technology something that is actually effective on the ground. With this model, I don't need then the doctors and the GPs to show up in every village. I can keep the GPs at the hospital, and even there, if an MBBS doctor is sitting at a district hospital, there are right now projects in progress in the Northeast, for example, with organizations like the 10-bed ICU, Cloud Physician, that are able to offer very strong support sitting from medical colleges and advanced technical institutions to these frontline operators to do fairly complex intensive care tasks, psychiatry. New work is going on in oncology, in cardiac work. Some training is needed, but I don't need an MD in cardiology. I don't need an MD in oncology. But I can actually bring some of these skills. Breast cancer, from what I understand, even stage 1 breast cancer, there is need for surgical interventions. You can't actually manage breast cancer entirely through chemotherapy. Some breast cancers you can, but many need some form of surgical intervention. An MBBS doctor can be taught how to do this surgery under the guidance of a good oncologist and actually manage some of these issues, right? With this kind of cascade of care, research that me and my colleague did last year came out in a journal called the Lancet. We were able to show that 12 Indian states, right now, current government expenditure is more than enough to deliver universal health coverage to the entire country, to the entire state. In fact, by 2030, what we find is that all but 4 large states, will actually have enough money, even if they don't change any allocations to their budget. The principal driver of this reality is that Indian costs of human resources are 1/20th to 1/25th of global costs. So our $25 is equal to $600, $700 in terms of actual expenditure on the ground. And of course, these 4 states need support, but our calculation suggests that a finance commission could actually allocate a small amount of money to make this happen. Once we go out of the curative element, where I believe it is possible for us to deliver, with the help of all of you, technology come human resource solutions to make universal health coverage a reality. But somebody may say, what about public health? How do we deal with that? One more strength India has that is we are one of the few countries that has a network of geostationary satellites floating above us that actually can look at the Indian situation, look at hotspots of malaria, look at bat populations, look at stagnant water, many things that other countries, even developed ones, don't have. Using that capability, combining that with machine learning, triangulating that with data that these community health workers are producing on a real-time basis, we will be able to build a surveillance system superior to what some of the others have been able to do in a much, much better way. And then, of course, there is the other issue of public health education. Again, there is, as we all know, we've heard the phrase, the WhatsApp university. Everybody, and their uncle is forwarding WhatsApp messages to each other about this fancy cure and that fancy cure. It's very nice work out of University of San Diego, where they have developed mechanisms by which they can quickly sense false information. In their case, they were worried about misogyny. It's a center focused on gender equity. Quickly pick it up on social media, identify the sources of it. And they have not done this work, but from my conversations with them, it suggests that it is then possible to start to emit opposite signals using the same tools that the misinformation people are doing to counteract this misinformation and replace it with high quality information. Combining all of that with work on social determinants, combining all of that with work on One Health, there is no reason why India, with our current resource capacity, with the help of all of you, can't deliver on the UHC promise. Thank you very much.
Thank you, Nachiket. As usual, Nachiket, so thank you so much. You have set the stage for a very interesting discussion, because we have practitioners here who say how infection prevention and how disease prevention are being worked on. But before I go to that, can I request Suresh? He, from Ernst & Young, he's looking at data in a very different and very kind of detailed manner to see how technology and frontier technologies, all kinds of technology and generative AI are going to change things. Do you want to sit there and talk? I like standing and talking to the panel because I enjoy that interaction.
No, thank you. Thank you, Deepanwita, and thank you, Doctor. Really a compelling fact base that you delivered in such a short time. Yes, so when I look at how can technology impact healthcare delivery and what data can do towards it, I feel in every aspect of the value chain, there is this role of technology in multiple ways, in providing new solutions, in understanding where those solutions need to apply, in kind of quality and cost of healthcare delivery and things like that. So let's take the pharma per se, and then say how can it impact new drug discovery. And we all know that the whole lead generation to the lead optimization process takes months. Today, with the use of AI technology and platforms, let me just go back, and for a conference in February, I was inviting someone from In Silico Medicine. They have kind of brought out a drug candidate in exactly 46 days for pulmonary, for a pulmonary fibrosis, right? Indication. And that is breakthrough. So In Silico Medicine is considered as one of the hot companies to kind of shorten this entire drug discovery process. And the same applies to many. The second person whom I got in touch with was from IAG. And this company is an imaging and analysis group. And they use imaging technology to kind of not only fast track development, but also fast track clinical trials. Also the use of synthetic data arms to kind of make sure that the protocols are much smaller, patients are recruited fast. And so there is tremendous value in bringing, we need to bring in new solutions, right? Today, Srihas of Biocon said 80 million diabetics. I know we are moving towards 100 million, 10 crore diabetics. We heard 25% is the prevalence of diabetes in Pathanamthitta, and I'm sure Amritsar and one or two places, Ludhiana perhaps, and by and large states in the south, Tamil Nadu has a very high average of diabetes. We need cheaper solutions and newer solutions to attack it, and technology promises to do that. The second one is, pharma has always thrown medicine at the disease world. I think a large part of it is where Dr. Nachiket Moore was going into saying, how is drug delivery, healthcare delivery impacted, right?
Correct.
So when you look at some of the platforms that are coming by, let's take the government's ABDM,
Yeah.
right? The UHI, as a fundamental basic pillar on which a UHC can happen, right? And how do we kind of make that happen? It requires, one is putting the framework, the second is kind of saying, how can we make it work? And this requires collaboration, participation, and a whole lot of things, right? So you have a UHI, which kind of brings in all the stakeholders, brings in a process of discovery, kind of smoothens, between the EHR of the patient to the provider. It kind of brings in a seamless transaction capability. Today with the PMJ insurance, you also, and people above 70 being treated free, you have virtually a very seamless capability to move this. But the key things are people in the ABDM. Today we have more than 60 crore Indians who have registered, who have ABA cards, which means they have a medical identity. They can take the medical identity to anywhere in the country and take treatment.
So
And
we've already gone into scale. So we are talking about how do we scale processes, how do we,
Exactly.
with the help of technology, can we come to Chandrasekhar Nair? If you don't know Chandra, I think all of you need to go and meet him. I'm not going to introduce, but he's our only unicorn in the health sciences space. Chandra, how are you handling scale? What is your company doing?
So we started 25 years ago with a dream to work on infectious diseases and diagnosis of infectious diseases. And it has taken us 25 years to scale. Not a great story, correct? The fact is that technology development and validation itself is a very long journey. And you learn every day about that journey, especially the part to scale. If somebody had told me that it's going to take you 20 years of existence to get a WHO approval for a product before India will implement that in its health program, I would possibly have run away. Correct. But the fact is that there is an unclear path to scale. The second fact is that there is only one consolidator of healthcare, and that is the government. And it is unclear as to how do you work with the government to achieve that scale. The rest of healthcare is extremely fragmented. So as a company, setting up a strategy to address that scale is an issue. But I take a great inspiration from Dr. Nachiket Moore's talk about universal healthcare and how as a country we must prepare to create platforms that will actually serve universal healthcare. Just before I came here, I was speaking to a journalist who was asking me, why do you have a leprosy test on your platform? Why do you have CMV and EBV and Nipah? And how many tests have you sold over the last 5 years? If we think like this, we will not create platforms or tests, and how are we going to be self-sufficient in terms of our diagnosis? Maybe I'm loud enough. Yeah. Oh, sorry. The other thing is that in terms of technology itself, we are creating a lot of impactful platforms. You will hear.
So we know
Just now.
TrueNat.
Yeah.
You talk about TrueNat a little and put in context what
So
is a larger.
TrueNat is a point of care PCR platform that you can perform PCR in the field. Today we have about 12,000 PCRs around the world, about 8,000 of them in India. Today we are in 85 plus countries. 14 of them are scaling TrueNat as we speak.
Correct.
We have sold about 40 million tests on our platform so far. And I think that number will see some acceleration unless global powers and global situations change that very dramatically in the next few years. I don't know how that goes. But I'm talking about other technology, and I'm talking about delivering technology to strengthen primary care, because we don't seem to learn from our epidemics. We had H1N1 in 2009. We made a lot of noise, but we did not do anything. We had COVID, it came, it went. We talked about strengthening primary care, and we are back to square one. But we have fantastic technologies. If you look at Haystack, which you'll hear from, but if you look at Niramai, that can actually do breast cancer detection at point of care. If you look at our own company Prognosis, which has now made a small digital X-ray, working with companies like QRAI or Deep Tech to deliver screening at very large numbers. Unless you screen very large numbers, we will never eliminate TB. And then you can reflex to a more sensitive molecular test or more specific molecular test. Or if you look at companies like Helium, which possibly have not been talked about because they work on ultrasound and the ability to auto-locate an organ. If radiologists are difficult to find, sonologists are impossible to find. But now with this technology, you can have primary healthcare doing an echocardiogram and sending that information wherever it is required to be sent, so that patients will get treated. There'll be a faster return to wellness. All of these very interesting combination of hardware and software and AI is making things happen. I have only one problem with our ecosystem, and I'm sorry, we are all part of the same ecosystem, and I want to put this out there. Somehow we focus on low-hanging fruit. Just because India is a poor country and we think that our solution should be also poor, there's a problem with that approach. Unless we bring cutting-edge technology, we will not be able to lower costs. And India should not be our market. The global south should be at least our market if we want to dream about scale.
That's wonderful segue to hear Anirban. Anirban, talk about your technology and how are you planning to really change the game.
I almost, he led it on to me. Right?
I know.
Right. So at Haystack, we are focusing on genomics and genome sequencing of infections. As of now, if when I'm looking at it in two parts. One is the doctor and the patient now and here. And the second is how long is the antibiotic going to be viable in the market for the population? These are two different problem statements. As we are working today, so every night, Haystack and our partners are sequencing 100 new genomes every night. Wow. And this is happening at our partner labs. This is happening close to the ICU. And the basic technology that we created, and that's the whole point. I think technology is a great enabler. Basically, what we created is we tried to take out the bioinformatics and the genomic scientists from sequencing, because they were the bottlenecks in democratizing of the technology. So today, a microbiologist in Max is using it, a microbiologist in Apollo is using it. And what we are able to do today is we are enabling the clinician to solve a second problem. The first problem the clinician is trying to solve is what they can see where the disease is apparent. Somebody comes in, you know that what is the likely case. All those patients for which it is not very apparent, I cannot see what is the problem. That is where genomics comes in. That is where sequencing comes in. That is where I don't want to ask the question, I am looking for a dengue, tell me if the dengue is there or not. I'm looking for malaria, tell me it is there or not. So by doing sequencing, we are enabling hypothesis-free questioning, and we are giving that answer. And with that, we are able to give the AMR profile using antimicrobial resistance genes. And I'm solving it for that patient and for that doctor now. But what I'm enabling the doctor and the patient and the healthcare ecosystem is not prescribe an antibiotic, which is not going to work. Okay. And therefore, I am extending the time for that antibiotic to be relevant in the population. And this is where I think India can lead, in my opinion, India can lead the way. Because in about 40,000 genomes that I have done now, I can very confidently say that only 5% of infections are caused by the WHO priority pathogens. Okay. 95% of them are not even on the kids. And this is where I think we are building the knowledge and the key opinion for the world to take it from here for the next journey.
So, the way I want to do it is now open up to a few questions and then I'll hear from the panel again. Any compelling questions anybody wants to ask?
Suresh, on the universal health record, but still it is not operable. If I go to Manipal Hospital, we have the electronic health record, and tomorrow the doctor moves to Apollo and I want to move that record or want to access, there is no accessibility. Still, we need to keep this hard copy and then I have to take it to the other doctor. So how to make it this, even though it is electronic health record, is there within the hospital, it is not universally available. And it's not linked to, I mean, we have a hospital number here, hospital number A, hospital number B. It is not linked. Can we use Aadhaar card number as a one thing where any doctor from anywhere can access? What is the system, what is the policy required in order to make it so that I not have to carry my all hard copy everything
Okay,
for
Suresh.
treating thing. So that is to Suresh.
Yeah, no, I got your question. Thank you. It's not a simple answer. The ABDM platform's objective was to kind of create that interoperability and kind of make the experience for the patients and the stakeholders smooth. And it also was supposed to bring in discoverability. I'm an arthritic and a diabetic. I want a dietitian and someone who, a physiotherapist. I can go into the platform. Now, what this platform mandates is participation. Today, what we don't have is, for various reasons, right? The Manipal hospitals of the world, or the Apollos of the world, or the general practitioners to register in ABDM. That's one of the big issues. You don't have, what will you do with data? Each one of them is standing in silos. The reasons are different. The business, nobody wants, once you give your data and when you share data into a public platform, you don't know what and how it will be used. So there's a lot of, and given that our healthcare system is broken and disparate, and there are multiple models, business models running, many of them don't want to put it on a public platform. So there are multiple ways in which you can make it work. Like I said initially, there has to be a willingness to participate in the future of creating a healthy country. And it will mandate that these big players kind of set an example for others to come in, right? So I think the primary reason for is the suspicion on data, at least as it is said. People say I'm hesitant because I don't know what will happen to my data, but inside there is something else as well.
Suresh,
So I think,
I'll just come
let me make one comment.
Sure.
So I think the main reason for success would be participation, and the system is there to create the interoperability. It is participation that is kind of creating that block.
Thanks.
Thanks. Can I ask one more question or no more questions? Sorry, go
Let's
ahead.
see if somebody else has a question. If not, Manohar gets it. Sure. Yes, Vijay.
Yeah. So just a quick technical question to Anirvan. When you say 100 genomes a night, these are metagenomes of microbial
They are.
infections. It's not human genomes, right?
No, it's not. So, and these are metagenomes from biopsies and all of that.
Yeah.
We are not sequencing the 100
Sure.
genomes a night.
Yeah.
Anyone?
Yeah, this is to Dr. Anirvan. So we have found that you are working especially on MDR, drug resistance, TB and all.
Yeah.
So you have done a lot of sequencing also. So what is the transition between MDR to XDR, XDR to TDR? Is there any mechanism involved in triggering those? How long is the frequency of changes happening? And in your sequences, anything you found a mechanism which is triggering them for the extreme drug resistance or total drug resistance?
So probably I should take this question mostly on the sideline because it's a longer part. What we have understood right now is so we do think from what we are seeing in the field right now, India will eliminate TB. I don't have a doubt about it. The problem is we will be left with a lot of MDR, pre-XDR and XDR TB. And that is what eliminating is going to be a challenge, because this transition from TB to MDR TB to pre-XDR TB to XDR TB is happening now. And this is being pushed by giving antibiotics, which are antibiotic cocktails, which are not completely active. So if I give 4 antibiotics and 2 of them are not working, then I'm pushing these, the 2 which are actually working into drug resistance. And this is the transition from MDR to pre-XDR to XDR. What we have found is, and this is also what WHO and others have also realized, is if you're able to get the entire antibiotic profile of a patient who is likely to be drug resistant, then choosing from 18 antibiotics, those 5, in which all of them work, reduces the chance of failure tremendously, but more importantly, reduces the chance of amplification of drug resistance in one of these 5 antibiotics, and that is what genome sequencing is being able to do. We can get a readout for a single patient in a single test for 18 antibiotics, basis which one can choose all antibiotics which are most certainly going to work for the patient, and we will avoid seeing a high frequency of transitioning from MDR to pre-XDR to XDR to TDR.
So is there any like co-infections plays a very important role, like HIV and other co-infections?
These academic parts I would request will take it outside.
We can do it.
It's my PhD and postdoc, and I can talk to you about it forever.
Okay, yeah, Vasan has a question. Before Vasan, you get the mic. No, please take the mic. 30 seconds. How long will it take for detecting? Because how quick the doctor can act on it?
So I think I was just discussing that with Dr. Nair. What NAT enables us to do is, and the question there is, the patient is there for a very short period of time, he needs the therapy now.
Yes,
and I think that is what MolBio has enabled.
Correct.
Where sequencing comes in is, if you're talking about a 5% people who need the whole genome sequencing, this can be given in a 5-day where the NAT is now, and within 5 days, we can actually have the entire 18 drug profiling available.
Okay, I just wanted to understand that part.
So that is only for TB, whereas for AMR, this is within the day.
Within
in
the
hours.
day.
Yeah.
Okay.
Yeah, my
Vasan.
question to Nachiket. You elegantly spoke about the barriers for local growth, where you mentioned 3 dimensions: healthcare, education, and finance. And you also alluded to the point that 10 states with the current amount of investment are able to really implement this effectively. What is stopping from other states in adopting this and making sure that this can be rolled out? And how do we sustain as we grow and the population increases?
No, just to qualify, Nachiket, I think you said that they are spending enough money to. You didn't say that they're actually meeting
so
universal.
I was going to
healthcare.
start with that.
Right.
That if I look at, for example, which are these states like Kerala, Delhi. Our estimate is roughly 2018 prices, 2,000 rupees per capita is needed to deliver UHC. Delhi is at 5,000 rupees per capita right now. Goa is at 5,000 rupees per capita. Himachal is at 3,500, 4,000 rupees per capita, spending much more than what is needed. Why are they not doing it? Many barriers. There's an enormous waste of money. I mean, the public sector in Kerala is doing more C-sections than the private sector in 3 districts. If I look at their primary care, right, a lot of us have interpreted primary care as diagnosis and prescription. The reality is, for many diseases, not the XDR, TB and all of that, where diagnosis is a real challenge. But if I look at diabetes, for example, which is a dominant condition on the ground, it's relatively trivial to diagnose diabetes. I can do a random blood sugar test. If it crosses 300, I know you're diabetic, even though you took the test immediately after lunch, right? It's a relatively quick, and I can test it 2-3 times to figure it out. The problem is you need adherence. You need the health worker to go out to the homes of these people to make sure that they are taking the medicines that they are supposed to be taking, or whatever other recommendations you have given. This has not happened. This issue that we talk about electronics, a state like Kerala, a state like Goa, a state like Delhi, forget the private sector. There are many competitive considerations, as were pointed out, why ABDM has not made the impact. In any case, many of these larger chains, their total market share and total revenue of healthcare is just 4%. So in a way, they are important because of brand, etc. But actually, in terms of the revenue share that they have, they are quite small, almost to the point of irrelevance. Right? The large players are indeed the government and a distributed set of private sector. The government is not investing in its own automation, using the platforms it itself has developed. In Kerala, during COVID, you saw so many gaps. They were not able to say what is going on. Right? So these are some of the considerations. You go to any government hospital today, anywhere in the country, it's full of patients. You go and have a chat with them. I was asked by 1 or 2 government hospitals to do this. 99% of the patients are in the wrong place. They needed to be dealt with in some primary care setting. You need gatekeeping there, but you need good services there, right? Before you prevent them from coming here. My own view is the idea of OPD in hospitals should go, right? There should be no reason to meet a doctor for a casual chat as an initial conversation. Many of these have not happened, right? Why is there so much waste going on? And this is why even those 12 states are not able to deliver universal health coverage, even though they have the money. And Vijay and I are on the Lancet Commission for reimagining healthcare in India, and we have proposed, not enough time to discuss here, but it's not as if we are the only country that had this problem. Many countries, the benefit of being a laggard, well, the problem of being a laggard is you're a laggard, but the benefit is there is a lot of countries we can learn from. And we are, I think, somewhere 140th, 145th in the global ranking in terms of healthcare systems. There's a lot we can learn from others that have done this.
One more question, because then I'll just ask 30 seconds to each, and I told Krishnan I'll try and close before time.
Once again, Dr. Nachiket, you told about geostationary satellite technology, and there is some concern about the GPS breakout in the country. So whether this kind of technology can be used to predict what will happen in the future and where it will go, is there anything available using this satellite technology?
No, you need both levels of information.
Okay.
The reality today is if I take a player like PharmEasy or take a player like Practo. Practo today has 400 million. It is the largest healthcare provider in the country by a distance, much bigger than government, right? 400 million patients. At any particular point in time, I don't remember the exact number, but somewhere near 10,000 conversations are in progress every instant. They know where GBS is taking place, right?
Okay.
Because there is diagnosis electronically accessible. I've spoken to Shashank, trying to persuade him to reveal this data. I think the concern many private operators have is they could get into hot water if the data that comes out is not consistent with the prior belief of the policymakers. But the data exists because some of this data you'll have to collect from the ground. What can you collect from satellite? You can collect, for example,
It's macro.
water stagnation, right? That is a big indication of where malaria might come.
Yeah.
Bat populations. One of the issues that you worry about quite a lot with bats are tiny bat populations that are sitting all over the place. You need dense bat populations deep inside forests. A place like Chhattisgarh, for example, can start to see what is going on. So satellite information, and you need machine learning there.
Yeah.
No human eye can actually detect the kind of variation that you are seeing there. Now, if you combine these two, if you combine the ground data with satellite data, I think we can deliver surveillance, disease surveillance, better than anybody else can.
Thank you. Yeah.
So I'll just go around and Suresh, last thoughts about where are we seeing the medical technology, healthcare technology in the next 5 years?
Well, let me start off by saying I have 2-3 minutes, right? 2 minutes.
1,
1 minute. Okay.
because Krishnan.
When we look at medical tech, med tech, you have 50% completely digital. You have 85% medical technology, and out of that 85%, 50% are digitally integrated, right? And that really brings out one crucial factor that will make it successful and help us apply it across the healthcare continuum, is how do we kind of remove the barriers for adoption? And when I say that, there are benefits of outcomes. And the fundamental for understanding this technology is the data that we have. Many a time we have data, like what was expressed just a little while ago. How do we find solutions to these problems? When you recognize that there are data sets, and what is the linkage between these data sets? Are they operable? Are they clean data? And therefore, what can you do from an analytics standpoint around that? And then you run AI layers and AI ML layers, and then probably generative AI to bring up the experience. So one is try and solve the problem and then build an experience. So I think this is happening in small pockets. One of the people known to me runs a startup called Fitterfly, and they actually have personalized medicine for the personalized treatment for diabetics. They have a continuous glucose monitor, and they help the patient self-monitor and then understand the glucose swings, and therefore accordingly manage treatment. So I think it is happening in small pockets. I think a large part of making medtech successful is the fact that we need to recognize everything that we do, the watches that we wear, the many OEMs that we employ in medical therapy, all of them emit data. What do we do about the data? What do we do about prevalence data? How do we connect all these dots? And I think the success, there will be, while we move slowly, there will be an inflecting point that will really create adoption at a mass level, and that will bring in more entrepreneurs into the system. And like they said, what UPI did to small entrepreneurs, UHI will do to medical entrepreneurs as well. So those are
Nachiket?
Just a quick comment and request to people who run incubators. One of the things I find is that when I'm confronted with digital technologies for health, everybody has built an end-to-end solution which is a bit of a Rolls Royce. Many of the names were mentioned earlier, which have terrific technologies. But if I were to imagine a primary care setting, I would end up with 7 iPads, with 7 cameras, trying to solve a bunch of issues. Because incubators have not bothered to create environments that actually constrain these developers to operate within something that looks like real life. And which is why go-to-market becomes impossible. Many of these companies are going to fail. Why? Because they were built in an environment that doesn't actually mimic any reality that we are trying to address.
Where do you see healthcare? And just if you can cover NCDs a little, because you talked about infection.
So I think we require better solutions for NCDs at point of care. If I am diabetic and I go to a doctor because I have a fever, he's not worried whether I have fever or not. Okay? But there is no way to get any data when you're in front of that clinician. And I'm sure tech is being built. I'm sure tech will be available. I have no worry about the tech, because there are enough people in this room and outside who want to create an impact. My worry is about transition to scale and path to scale. That is not visible for most entrepreneurs. Somehow as a community, we have to figure that out better.
Anirban, you get the last chance. Yeah.
I think I was just fascinated by Dr. Nachiket more pointing out that 99% people in that hospital is in the wrong place. And when I've always seen it from the point of view of technology that is available, and it is just very obvious that hospitals are supposed to be are built for intensive care. What we are going to see in hospitals, so a technology like a NAT and every other POCT is going to be way more distributed. By the time somebody comes to the hospital, it needs to have very, very high-end technology, and that's where I think we come in. And in that space, I think somewhere between 50 to 70% of most of the screening that is going to happen in very high technology space like omics, multi-omics, and AI-driven vision. And I don't have any doubt about that. Whether public health is going to drive it or the manufacturers are going to drive it, I don't know that yet.
Thank you. So, Vijay, you mentioned point of need. I think we are talking of the point of, not point of care necessarily, but you said point of need as you in the morning. And I think we are talking of point of need care, point of need delivery. With that, thank you very much. It's a great panel, and just give a round of applause.
As we conclude this insightful TechMed session, I would like to extend our sincere gratitude to our esteemed speakers and panelists. A heartfelt thank you to Ms. Deepanwita for expertly moderating this session. I request Mr. Krishna Mohan, Senior Vice President, Planetary Health and Regional President, Middle East, India and Africa, Novonesis, who is a patron gold member of ABLE and also the gold sponsor for the event, to please come to the stage to present the token of appreciation to our esteemed speakers. Thank you, Mr. Krishna Mohan, sir.